So again, welcome everyone for joining today. The Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, June the 16th. So welcome everyone for joining. On the call with me today from the STSI, we have myself, we have Addie, Banu, Emily, Nancy. Nancy Honeycutt, Nancy's new to the team. For those of you that have not met Nancy, Nancy is our new adult database, as well as Intermax and PDMax. She is the new database manager for those databases. So welcome to Nancy to the STS team. We're happy to have her on board, and she is also a fellow North Carolinian. So welcome to the team, Nancy. Also, we have Paul Meehan and Sydney Clinton and Ruth from our STS, as you all are aware, Ruth is our STS GTSD clinical consultant. So thanks everyone for being on the call with me today. All right, so quick agenda, you guys, typical agenda, nothing new here. I'll just provide some brief STS updates, and then I'll turn things over to Ruth. And then as usual, we'll finish up with our Q&A. Please be sure to submit your questions via the Q&A. I'm gonna go ahead and turn the chat off. So again, please be sure to submit those questions via the Q&A function. And then also we do have the raise hand function enabled. So if you'd rather just talk to us one-on-one and just ask your questions, we are happy to do that. Just raise your hand and I will unmute you, and just make sure that the microphone is enabled on your end. So with that, let's go ahead and kick things off. STS updates, the June training manual will be posted, should be posted by the end of this week. So keep an eye out for that. The spring 24 harvest reports, just a friendly reminder that those were released on Monday, April the 29th. So if anyone has not found your report, those reports were posted back in April. Official notification was sent out to the participants on Friday, April the 26th, notifying that those reports were available. We are currently accepting data for the fall 24 harvest. That harvest is scheduled to close September the 6th. The fall 24 harvest includes surgery dates of July 1, 2021 through 6/30, 2024. And the opt-out date for that fall 24 harvest is September the 10th. So if you have any questions or anything, just please let us know. GTSD audit update. Official notifications were sent to selected sites on Wednesday, June the 29th. Audit-related questions should be directed to CRS, so just reach out to them directly at genthoracic@cardiacregistrysupport.com, and then Kathy and her team are happy to assist those that are undergoing the audit. And we did have an audit webinar earlier for those sites that were selected for audit. So that webinar was recorded, and Emily has sent that over to our marketing team. And that webinar is still to be posted out on the STS website, but keep checking the STS website, and that webinar will be posted as soon as possible. I would give you a date, but we don't have an update yet from the marketing. That will be posted ASAP. All right. Oh, did I say, I'm sorry, I was just looking at the questions real quick. June or May, did I say May 14th for the June training manual? But the June training manual will be posted no later than June 14th. I don't know why mentally I'm stuck in May. I have no idea why. So sorry about that. But for those that have been currently harvesting for the fall 24 harvest, for those sites that are currently harvesting, you are aware that there is a new NPI validation for sites using the third-party vendor software. For those of you that have not yet begun submitting data for harvest, this is a new NPI this is a new validation that you may encounter while you are uploading your data. The purpose of this NPI validation is to ensure that only cases for surgeons, which you don't have anesthesiologists, but for surgeons or anesthesiologists on your contract list are accepted into the database. If a case is uploaded for a surgeon not on your contact list, the record will fire a critical error, and that record will not be accepted into the database. STS did send out an official communication regarding this new NPI check to participants on May 10th. So we ask that prior to submitting your data for harvest, review your contact list to verify that the surgeons STS has to verify the surgeons STS currently has on file for your sites. You can access your contact list report within the IQVIA platform. It's found under the operational reports tab within the platform. And if you do find that any of your surgeons are missing from STS records, they're not included in that contact list, please complete the required documentation. Again, it is a contractual requirement and must be done as your physicians join your site. So as you get new physicians incoming, please go out to the STS website, complete a participant contact form, and get their signature on that Schedule A and get that submitted to STS as soon as possible. Same thing if a surgeon is leaving your site, you do need to remove them from your let the STS know that that surgeon is becoming inactive at your site. So you would complete a participant contact form indicating that that surgeon is going to become inactive, should no longer be associated with your site, and then you would provide a date that surgeon became inactive at your site. So if you have any questions regarding the NPI validations, please reach out to us at stsdb_helpdesk@sts.org. And our STS database team will be happy to help with any questions related to the NPI. Next, AQO update. So again, join us. We hope you are able to join us in Nashville, September 11th through the 13th for our AQO meeting, data managers meeting. We'll be again in Nashville, Tennessee this year. As you are aware, AQO registration is now open, and reserve your housing. Again, I've supplied this information before, just the in-person pricing as well as the virtual pricing. We'd love to have you in person, join us in person. If you're not able to join us in person in Nashville, we do have the virtual pricing available as well. The call for abstracts, we are currently accepting abstract submissions for AQO this year. The submissions will be presented as e-posters, while a small number may be selected for oral presentation. The deadline for abstract submissions is Monday, June 24th at 11:59 p.m. Eastern Time. If you have any questions about abstract submissions, I think they would contact you directly, Emily. Is that correct?
With questions, yes.
For abstracts, yes. For
yes.
For questions for abstract submissions, again, just reach out to Emily directly.
Yep.
And I believe did we put your email in the chat box?
I can do that. Oh, yeah. Can you make me a co-host?
Oh, sorry about that. Absolutely.
No problem.
Sure thing.
And then I'll put it in there. Thanks.
Absolutely. Sorry about that. Sorry, everyone. Okay. So Emily, you're now co-host, but yeah, so Emily will put her contact information into the chat. So again, questions regarding abstract submissions, just reach out to Emily directly and she'll be able to assist there. So we would love to have general thoracic abstracts this year. I believe we had maybe one, maybe two last year. I believe the year before that, I don't think we had any, but again, we would love to have your abstract submissions this year for general thoracic. So please get those in. And again, the deadline is Monday, June the 24th. I've included some of our preliminary agenda topics. We've had 2 meetings with our AQO planning committee. Some of our topics include, we'll have lung and esophageal case scenarios. We'll have a presentation on the neoadjuvant therapy module, GTSD revised risk models and the short, as well as short and long-term risk calculators. We'll talk about post-op events. We have a data manager and a surgeon doing a presentation on division of responsibility, the data manager versus the surgeon, using STS data for quality improvement, interpreting harvest reports and star ratings. Some of our on-demand topics will include harvest prep, operative techniques, hernia, mediastinal mass, tracheal resection. And again, this is not set in stone, but it is subject to change. But these are the topics that we have on our agenda at this time. So Some tweaks, minor tweaks may still be done, but again, these are some of the topics that you can expect to hear about at AQO 2024. Speaking of AQO, we have a couple of asks. So we would love if you all could send us copies of your PFT reports. We would love to have examples of your PFT reports and pathology reports. I know when Ruth, Ruth's given education on them, and there's so many different versions of PFT reports out there and pathology reports. So the more examples that we can have, the better that we can interpret, we can add into our AQO presentations. So again, if you have examples of PFT reports, pathology reports, please send these to Ruth. Her email address is here, or Raleigh@sts.org. And we would love to have these examples by July 12th, if at all possible. So again, we're asking for copies of PFT reports and pathology reports that we can utilize for our AQO presentations and provide the best education possible that we can for you all for this year's AQO. All right, that's all that I have from the STS side of things. So next I'm going to turn things over to Ruth.
Perfect. So for this month's education, I want to just sort of go back to the basics and talk about which cases should be included and excluded for both lung resection and esophageal resection. If you want to go to the next slide, Leanne.
Oh, sorry. Thank you.
Okay. So the STS requires the inclusion of all cases that are primary resections of new lung cancer and primary resections of new esophageal cancers. There are, of course, the optional modules, and then ultimately there are still sites that enter every case that their surgeons perform, which is also fine. But if you think about the way that the data collection form is currently set up, you can see that the STS clearly had in mind that the cases that we are collecting are primary resections of new lung cancer and primary resections of new esophageal cancer, and that's really what they're trying to collect data for. The optional modules, of course, have great questions related to those optional cases, but if you're entering something like a deportation, the form is a little bit less relevant, which is intentional. If you want to go to the next slide. So again, we're cases that are excluded. So lung resections, not for new lung cancer. So things that would be excluded, benign lung disease. So wedge resections for sarcoidosis, or if there's a wedge resection or even a lobectomy that's done for a pulmonary nodule, and that pulmonary nodule turns out to be like a benign hamartoma, for example, that case is not required for entry. Metastatic lung disease is not captured. So if you've got metastatic ovarian cancer, even if there's like only a single site in the lung and they do a wedge or a lobe or whatever, you would not need to include that case. Recurrent lung cancer is not captured. Sometimes it's a little hard to tell if something is recurrent or not. You can always check with your surgeons and they can provide clarification for you. Diagnostic resections are also not required for entry. And again, sometimes it's tough on some of these cases to parse apart whether something is diagnostic or therapeutic, and your surgeons are going to be your best resources for that. The other types of cases that are excluded that you do not have to enter: esophagectomy, not for esophageal cancer. So for example, esophageal perforation, which is what the picture on the right of your screen is an example of. Esophageal fistula repairs, and then again, the same thing as with lung. Recurrent esophageal cancer would not be captured. We're really looking for de novo cancer cases. And the reason for that is the outcomes for recurrent disease and new lung and esophageal cancer cases are very, very different. And so the STS intentionally tried to scope it to these new cancer cases. If you choose to enter a recurrent lung or esophageal cancer case, again, that's okay. Some sites enter all cases. You'll just want to make sure that you answer no to the sequences that are asking you if these are lung and esophageal cancer cases, because that's what's going to pull those cases out of the harvest for you. Go to the next slide. So these are some examples from the FAQ inbox of cases that I've been sent and asked, do I include this one? Do I not include this one? And I thought it might be helpful to just walk through some of these cases. So in this first example, so we're going to go through lung first and esophageal cases at the end. So this first patient had a biopsy of a left upper lobe nodule, which was clinically staged as a T1A N0M0 adenocarcinoma. So this patient does indeed have lung cancer that's biopsy proven. They went to the OR to have a left upper lobectomy and a lymphadenectomy. Intraoperatively, things went awry and they weren't able to complete the left upper lobectomy. They did 2 lower lobe wedge resections and the lymph node dissection. You want to go to the next slide, Leanne? So this is the pathology report for this case. I'll summarize it for you and you can look at these slides online later and sort of dig into the detail. But what you'll see when you read through this is that there was no lung cancer in either of the wedge resections performed. It was granulomatous disease. And then there were no positive lymph nodes. So essentially this case is excluded because it's not a lung cancer resection. Does the patient have lung cancer? Yes. Was this a lung cancer resection? No. So this case does not have to be included. Essentially it ended up being a diagnostic wedge resection and they discovered that the patient doesn't have left lower lobe lung cancer, which is still a valuable surgery. It's just not a surgery that has to be included in the registry. If you want to go to the next slide. In this case, patient Y has a history of rectal cancer within the last couple of years and got chemotherapy. They're currently admitted for a lung nodule and they had a wedge resection. The pathology report showed metastatic rectal cancer. In this case, it's a great example of why you want to start at the end and not at the beginning of your case when abstracting. If you would look at the pathology report first, you would see the rectal cancer on your pathology report and know that you really don't need to go any further, that this case is not required for entry and you can move on to the next case, making a note on your case log that you didn't put this one in. I'm going to go to the next slide. And again, another very similar case. So a patient had a right VATS excisional biopsy of the right upper lobe. It turned out to be adenocarcinoma of the colon. It was a metastatic deposit. They wanted to know whether to include the case or whether it's a concomitant procedure. It's really neither. You don't have to include the procedure at all. If you were going to include this case, your primary category of disease would be lung tumor metastatic and not a lung cancer primary category of disease, which would of course throw it out of the harvest analysis. Sorry, you can go on the next slide. This patient, another lung example of an excluded lung case. This patient had prior squamous cell of the right upper lobe in 2020, and now they've got a left upper lobe mass. Intraoperatively, the surgeon noted that they elected not to proceed with any surgical resection of the mass. It was attached to the phrenic and lower current laryngeal nerves, I assume, making it a T4 lesion. The data manager noted when they sent in this question that the pathology didn't include a T-score or any other information such as tumor size, T-stage, histology, grade. They contacted their pathologist, which is great. I encourage you to reach out to your pathologist if you have questions about pathology reports. And the pathologist said that no synoptic report would be issued because there wasn't sufficient material to create a synoptic report. So whenever you're missing pathological T and N staging in your pathology report, it should trigger you to sort of dig a little bit deeper and see, is this really a therapeutic lung resection? Do I really need to enter this case? And in this case, they did not. Okay, here's an example of an excluded esophageal case. So this patient had Crohn's disease. They had multiple fistulas between the distal esophagus and the left lung. The patient originally had a thoracotomy to try to take care of the fistulas and resect the lung. Ultimately, this failed. So they went back to the OR and had an Ivor-Lewis esophagectomy. While this patient had an esophagectomy, it's not an esophagectomy for esophageal cancer, and so it's not required for entry. It can be entered, but again, the primary category of disease for this case would not be a cancer primary category of disease, and so the case wouldn't be included in the analysis for this site. And I think that's the end of my quick run through of cases that you don't have to enter, but I'm always happy to take a look at these in the FAQ inbox. But your surgeons and your pathologists are really your best resources in many of these cases. So feel free to reach out to them as well.
Thank you, Ruth. Sorry, let me bring this back over here. Upcoming webinars. I see we have some questions into the Q&A. So yeah, just continue to put your questions there in the Q&A. Just really quickly, our next monthly webinars are scheduled for July 10 at 2:30 Eastern, and then August 14th at 2:30 Eastern. So next, let's go ahead and hop over to our questions. And then first, May 29th for audit letters. Is that, I assume I probably misspoke while I was reading what I typed out. So let me know if you need any further clarification regarding the audit letters. Next question from Nancy. Cannot view the anesthesiologist contact list for congenital or adult. Who can I contact again? Nancy, reach out to STSDB. Oh, go ahead.
Yeah,
Paul?
actually, yeah, Leanne, I could jump in. So the contact report shows your current active surgeons and anesthesiologists. If somebody doesn't show up in that list, it's because you don't have them as active surgeons or anesthesiologists. So if you have no anesthesiologists showing up in your list, it's because you don't have any active anesthesiologists. You need to send in the participant contact form for all of your anesthesiologists. So that's what's happening there.
Thanks, Paul.
Yep.
All right. All right. So question from Tracy. If we remove surgeons that are no longer with our facility, how does that affect our prior cases when we submit data? For example, if we resubmit data from 2023 for a harvest and a surgeon that did those procedures is no longer on our contact list, are those cases still included in our outcomes reports? So the answer, yeah, go ahead.
Oh, I'm happy to take that one, Leanne.
Sure, go ahead, Bono. Yeah.
So when we remove surgeons from the list, we don't actually physically remove them, we just deactivate them, and there's a deactivation date. So if you are sending your cases and those cases are prior to the deactivation date of the surgeon, the system will accept them. But if your surgeon is deactivated and you're uploading cases that are past the deactivation date, that's when it is going to give you a critical error as well. So you need to contact us and make sure that we have an updated Schedule A form so that we can reactivate them and you can successfully upload your cases.
Awesome. Thank you, Banu.
Sure.
Perfect. Next question. Emily, this one's, I think you could probably best answer this. Can we download slides from the audit related webinar?
We will post them on the website on the, if you go to resources and then you go to STS database audits and then it says login required. That is the link that you'll click, and then the webinar and the slides will be there. They're not there just yet. Marketing is working on it, but that will be the home for it. And then the login information is the same as the information you use when you access your data collection forms on the website.
Perfect. Thank you. Our next question from Stephanie. Stephanie, I have a quick question. Are you a direct data entry site? Or do you use a third-party vendor software? And she is wondering, where does the NPI validations show up? She mainly inputs the cases and have not come across any NPI validation error. So it just depends if you're using direct data. Yeah, go ahead.
Direct. Yeah.
I'm sorry, she is?
She's direct. Yep.
Okay. So Paul, direct data entry, they would show up when she's entering the case?
Yeah, you'll only be able to select surgeons and anesthesiologists that you have sent in the Schedule A and the Schedule B. So you've put in the contact information for them already. That's how, when you're entering the case, you can only select ones that are active.
And Leanne,
yeah.
Okay.
And as you mentioned, Leanne, at the start of the webinar, if I remember correctly, it only impacts participants using a third-party software vendor. So if they're direct data entry, it's not going to affect them. They will be able to enter using the drop-down menu.
Awesome. Perfect. Thank you. Thank you, Ruth. I didn't see. Oh, you're welcome, Stephanie. Thanks, Banu. Thanks, Paul and Ruth. Let's see here. Okay, Ruth, for recurrent lung cancer, if a patient had a previous adenocarcinoma tumor removed and then later develops a tumor that is not adeno, would that be considered a primary?
It'll depend on whether it's lung cancer, assuming that it's lung cancer. So like if it's proven to be like a typical carcinoid or something like that, then yes, that would be considered a new primary lung cancer. You just want to make sure that you're not abstracting metastatic disease still.
Alrighty, so next question from Mindy. Are the lung resections entered that are not required, no lung cancer, still included in the legacy reports and the non-risk adjusted dashboard? So I'm going to the benchmark and legacy reports. So Mindy and this, I'm not sure if everyone is aware, but the criteria to be included in the benchmark and legacy reports, this procedure specific section, the criteria for these reports can be found in the analysis overview. So for those procedures, here's the criteria for them to be included into the benchmark and legacy reports. And then they would, would also be included in the non-risk adjusted dashboard, Mindy, yes. And Heather states, Emily, that they will be submitting an abstract. That is awesome.
Yay. Awesome.
So, yeah, that's awesome. Thank you. Sherry, okay, yes. All right, so question from Laura. Ruth, I don't know if you had a chance to read this one. Do you want me to read it? Happy to read it out loud.
I'm reading. Can everybody see the questions? I've always wondered this and I've never asked
Yeah.
you. Okay.
Yeah, they can see the questions.
Sorry. I'm like, oh gosh, I probably should have been summarizing these questions for like years. Patient is admitted by another specialty and had a planned lap hernia repair. The patient had a gastric perforation. Same day, hernia repair. You can enter the case, Laura, it's fine. Ultimately, these optional modules, it's just data that's provided back to you. There's no risk adjustment or anything like that for these cases. It's certainly a complicated hernia repair, but it is a hernia repair, it looks like, just based on your brief note. So it would be fine for you to enter that case.
All right. And there's a clinical staging question. I don't know if you can answer that one.
Yeah, so if your perception of clinical stage disagrees with the surgeon's documented clinical stage, then I would just reach out to your surgeon and have a conversation on why, they believe that it's T2, but you came up with T1. And sometimes it'll be that they made a mistake. I've been in rooms with patients having conversations with thoracic surgeons, and the patients have pulled up on their app, like, but isn't this actually? And the surgeon will be like, oh my gosh, you're right. So, I mean, they do make mistakes on this sometimes too, on the fly. But I would just have that conversation with your surgeon. Ultimately, you'll have to hash it out with them.
Right. When will the analysis overview update with all resections? Let's see here. The next analysis overview update will come out just prior to the fall 24 report. So that'll be the next iteration of the analysis overview update. Came across the case. Let's see here. Here you go, from Anna. I came across the case and I'm not sure if I should submit due to the patient's age. We usually only have adult patients, but this one is 13. Do we only submit adults regarding the same case? I'm not sure what the appropriate code would be for.
I don't know offhand, Leanne, I'd have to pull up we never do pediatric cases, so.
I don't think you would, and
Look,
that's what I'm pulling up. Trying to see what we have in the training manual, to be honest.
I mean, the patient's age has a low of 1 and a high of
Yeah.
110. I can't remember. I would have to look in the analysis overview if these patients get thrown out of the analysis though, based on
I think they,
age.
yeah, I don't think they are included in the analysis. Hold on, let me pull up the overview. Let's see here. Where's Harris when you need him? Right off the top of you. It doesn't say, which we can clarify. Honestly, it doesn't. I don't think it would be. I honestly, that's a great question. I don't see anything regarding age being under the age of 18 as a requirement, or over the age of 18 as being a requirement to be included in the analysis. That's a great question. Just as not missing age.
If you want to just email me your question, Anna, and then we can follow up with Harris and get back to you.
Yeah. Yeah, I'm not seeing anything regarding the, age must be greater than or equal to 18.
And if you can just include in your email the question about CPT, and I'll give you a CPT for your procedure too. The tumor size change, the follow-up question to the disparity between the clinical stage that they came up with and the clinical stage that the surgeon came up with. They said that there wasn't a mistake. It was just that time had elapsed. Again, I think you need to follow up with your surgeon because it looks like your tumor shrank over time, which is unusual. As you said, within 4 months, T1, longer than 4 months, T2. So it would be atypical for something to shrink, but usually you would use the imaging closest to the procedure. So it may just be that your surgeon, I don't know when they wrote their note compared to when you evaluated the imaging. Sorry to not be more.
Yeah, she's. I can take the next one, Ruth. My surgeons say they have not received notifications saying the change from lobectomies to resections for star ratings. Was this sent out? So no, their official communication has not gone out. I know in our last webinar last month that I talked about for reporting, we were going to be, utilizing the revised risk models. We are currently working on the details regarding implementation, and we're continuing to work through it, and we'll share more information as discussions progress. The hope is to have them implemented in fall 24. I don't know if that's going to come to fruition. We're working with the analysis team and surgeon leadership to see if it's feasible to get it into the fall 24 analysis. Obviously, we need to provide details to data managers, to surgeons. So there's still, like I said, discussions are ongoing. I will share more information with you as soon as I have it. Also, there will be formal communication going out regarding public reporting, switching to, we discussed public reporting would be switching to the resections. Official communication will be coming out to from STS to surgeons because of consenting and things like that. All that communications will go out before obviously anything is implemented. So just stay tuned. I will share more information with you during our monthly webinars as soon as I have more concrete dates and more specific information. But please let your surgeons know that nothing has gone out officially at this time from STS regarding that change, but it will be coming. Next question, Ruth, clinical question, post-op event.
Sure, it looks like a patient had bladder scans, they were retaining urine, and they attempted to catheterize the patient multiple times and were unsuccessful, as often happens. They wanted to know, and then the patient ultimately didn't end up needing to be catheterized. After all of the unsuccessful attempts, they wanted to know if it would be captured as a post-op event. Yes, your patient had urinary retention and they were catheterized, even though unsuccessfully, so it would be captured in sequence 4000 as a yes.
Excellent. All right. Again, just monthly webinars coming up. I don't have any other questions. Just gonna stall for just a minute just to see if anything else comes in at the last minute. Again, next upcoming webinars, July 10 and August 14th. And here's our contact information, ljones@sts.org is the best way to get in touch with me. Again, if you have any questions related to your harvest reports, if you're seeing something in your harvest reports that you don't understand, your numbers aren't matching, what you're seeing in your database or what you're expecting, please email stsdb_helpdesk@sts.org. All those questions need to be directed to the help desk first so we can get a ticket generated, and then we can work to get your questions answered for you. It's hard for, unfortunately, I can't answer those questions directly. I don't have access to everyone's reports. So again, any harvest related questions, report analysis, report related questions, please send those to stsdb_helpdesk@sts.org. And then if you have any questions regarding contracting and database participation, you can reach out to stsdb@sts.org. If you don't know who to contact, you can start with the help desk, you can start with me, and then we'll get you pointed in the right direction. So we're here to help in any way possible. All right, Ruth, I'm not seeing any more questions come in. So with that,
Leanne, just one last thing to add in.
Of course.
When you're mailing help desk, it helps pick one, just one. Sending it to all of them just creates more problems. So, just the DB help desk is probably the first place to start, and we'll get you directed into the right place if we're not the ones to answer the questions. So, but yeah, mailing all of them just adds confusion to the problem and slows things down.
Thanks, Paul.
Yep.
All right, and again, just a friendly reminder, if you can send Ruth a copy or an example of your PATH report, a PFT report, we would be immensely grateful. It'll help us out in our AQO presentations, and we can help us provide the best learning experience for you guys, and we can have a good, successful AQO. Thanks, everyone. Thanks, everybody, for being on the call with me today. I appreciate you guys so very much. Hope you guys have a great summer, a great June and July. We'll see you next month.